Good morning. Am I audible?
Yes, audible. Yes, audible, Aisha, audible. We will introduce you.
Namaste, ma'am.
Namaste, namaste. We welcome you, Aisha. We'll introduce you and then you can start.
ठीक है मैम.
Yes.
Yes, ma'am. Start. Bobby.
Hello, everyone. Am I audible? Hello, everyone.
Yes. Yes, ma'am.
Okay.
Yes, ma'am.
I welcome you all.
Yes, ma'am.
Okay. Now, please put off your mic, please. Okay. Hello, everyone, and good afternoon. On behalf of College of Nursing AIIMS in Delhi, I welcome you all. As a part of Regular Series Alumni Speaks, today we are conducting Alumni Speaks Hashtag 2. First, we have done on 5th of June, and it was done by one of our alumni, Matilda, on journey of nursing informatics. This all happened because of the initiative taken by our principal ma'am, Dr. Lata Venkatesan. She it was her idea and she only started this. I welcome you, ma'am, and please say a few words about this webinar series and how we are going to do further or how we are going to move further. Ma'am, please.
Namaste everyone, and I'm extremely delighted to host this alumni webinar series. And we have started with hashtag 1, 2, and today we are so happy to have the speaker hashtag 2, Aisha Abadide. She is here to talk about the aviation nursing. And in a few weeks before, we started a WhatsApp group to get connected with alumni. I have joined here maybe as principal 6 months before, and I was extremely curious to know where are our alumni, what are they doing, and I understood that our alumni are placed across the globe in distinguished positions. Then we all had the interest that all the students who are studying here should know about our alumni and should get inspired with the positions and responsibilities held by our alumni. So to motivate the younger generation, we thought we'll connect them with our alumni. And alumni also felt very happy because this is their alma mater and it's like homecoming back to AIIMS. And many were recollecting their fond memories, how they enjoyed in this campus as a student. And we are extremely delighted to get connected with all of you. I always used to say the umbilical cord may be cut, but the relationship continues. So that's the kind of relationship we want to have with our alumni members. And we will keep inviting one by one. All of you will get the chance. Be prepared and be ready to talk to the students and rest of the alumni webinar series. And I requested Madam Kiran to be the host of this program because she will be knowing all the students who study here. She is one of the senior most faculty and alumni of AIIMS College of Nursing. So I asked her to coordinate this program so that she will be able to better share the memories about the alumni. And we created a Telegram group because in Telegram group we can accommodate more number of participants. We can accommodate up to 2 lakh participants. So now currently only around 400 members have joined the Telegram group. Please motivate your own classmates and the alumni, rest of the alumni members wherever they are working with, please connect them to the Telegram group, and we will be so delighted to stay in touch with you, and we can plan for more activities, not only webinars. Webinars are only to begin with. We can plan much more and higher scale of activity engaging the alumni members. So once again, I welcome all of you, and especially I'm thankful to Aisha. She is very busy. She was traveling to UK and she's flying to various parts of the world. And when I asked her immediately, she accepted. Okay, I will definitely do it. And yesterday I received her slides. All of us are very curious to listen to your session, and this kind of specialty is not available in India. So many students were messaging me, Madam, we should have such position in India as well. So that is the kind of response we have received. So Aisha, we are all eagerly waiting to hear from you, and Madam Kiran will introduce you. After that, you can start with your presentation. So thank you all. Stay connected and encourage us in all the activities we are offering. Thank you.
Thank you very much, ma'am, for the kind words. So I welcome Babaji Aishar. Aishar, I pronounce you correctly because your first name is like Babaji Aisha. So she is, as ma'am said, alumni of College of Nursing AIIMS. She did her joined nursing in 2008 and passed out in 2012 as a foreign national from Nigeria. Uh, Today she is going to talk on aviation nursing. It's totally new topic. As for to me also, when ma'am said, Kiran, you have to organize this one, I said, ma'am, aviation nursing, what are we doing this? Then she gave me the details of Aisha and I was really surprised. So I am very happy to know that you're working here as an aviation nurse and really are working very hard. She did her course of certified flight nurse of CFNR, so certified flight registered nurse. She did her course from UK and USA, and she has done also diploma in aviation medicine. You all will be surprised to know that when we are working as a flight nurse or you can say aviation nurse, we have to know the technicality of the flight also. So she's also trained as a co-pilot for helicopters, and she knows the technicality of the wings plane. Whenever any problem and anything comes, she should be able to manage. So really, congratulations, and very happy to know that one of our students and one of our alumni is working and doing such a great work and especially for humanity and all. So now it's to you, all of this screen to you, Aisha. You can start now.
Thank you so much, Madam
Okay.
Kiran. It's a privilege to be here and to participate in this program. I thank you, Dr. Lata, for this opportunity that you've thrown to all of us. And I'm glad I'm today's alumni and I'm Amazonian, and the basic foundation you guys have given us has taken us to so many places, and I want to be, I'm grateful for that. Thank you so much. Um, I'll be talking about the aviation medicine as Madam Kiram has introduced me. I'm the flight nurse manager for National Emergency Management Agency and an aeromedical consultant for 99 Medicaid in Nigeria. What actually prompted me to go into aviation medicine is because it's a new thing entirely. Everything we do, it's always just about the bedside nursing, and I realized nursing we can actually spread our tentacles to various things, so many things. The same way we have the goal of managing patients and helping them, the same way we are doing also inside the ambulance to do the same too. So I'll be going on to my presentation now. I know everybody has been asking the question, what is aviation nurse, not about who is an aviation nurse, what is flight nurse, what do they do. So let me go to my presentation. Thank you so much.
Aisha, keep your slides open. Then you click on share presenting and click on it.
Okay, the slide is open now.
But now you have to click on the share presentation. Right side.
I think it's
Just
sharing
go
now.
for, yeah, chat, but just go to presentation mode. Just go to presentation mode. In full screen.
Presentation mode.
Yeah, full screen. Make your screen full.
It's already on full screen. Let me go there.
Maximize your screen.
Bobby.
It's maximized. The screen is maximized.
No, I think one thing, when you started sharing, presenting, you could have flipped the entire screen, not the window.
Now it's okay. Now it's fine.
Can you see it now?
Yes.
Yeah, but just maximize it.
Share screen.
No, just go for the.
Okay.
Just skip that. No,
Ah,
yeah,
click
yeah,
this.
yeah,
Yeah, yeah, yes.
yeah.
Yes, now it's okay. Okay, start.
Is it better now?
Yes, yes.
Yes.
Okay, so we're going into this is the course structure. We go through the introduction, the need for aeromedical transport, aviation physiology, and the physics of atmosphere, gaseous exchange, primary survey, resuscitation, and secondary survey, understanding hypoxia and altitude, the types of transfer we do, the retrieval platforms, aeromedical presentation, and the preparation, roles of flight loss manager, phases of coordination, the common coordination problem that we encounter, checklist, pre, intra, and post-flight loss duty, oxygen calculation, and documentation. So first of all, before we go into the course proper, we keep asking ourselves the question like, what is trauma? I'm going to make this presentation an interactive one, so yeah, everybody can contribute to the presentation. So trauma, as we all know, is defined as an injury to living tissue which is caused by an extrinsic factor. It could be anything. It could be accidents. It could be a domiciliary issue, and we all know now in America they range it as the trauma has been the one of the leading cause of death in all age group, especially people under 44 years of age, and it has accounted for the loss of many lives compared to the atherosclerosis and cancer in combination. So, what is a retrieval? Retrieval is a coordinated process that provides a specialized assessment and management prior to and during the transfer of critically ill patients from situations where resources or service are inadequate to a destination where definitive care can be provided. So, am I still audible, please?
Yes, well, just a sec. Just a sec.
All right.
All right, now you can continue.
Hello?
Yes, Aisha, you can continue now. You can continue now, Aisha.
Okay, ma'am. So the retrieval medicine, it's a coordinated process that provides specialized assessment and management prior to and during the transfer of critically ill patients from situations where resources or services are inadequate to a destination where definitive care can be provided. Meaning, the retrieval medicine is done because most of the patients that we evacuate that usually have the remote area where the medical facilities are poor. So it's easier for us to move a patient with an helicopter from that area to an area where they can receive a proper care. I mean, like a trauma center. You can give an example of having a disaster in Bihar and they want to move a patient to AIIMS. We can see the distance from AIIMS and from Delhi to Bihar. So it's easier to use an helicopter from Bihar to move a patient to Delhi. For example, a patient that has a subarachnoid hemorrhage or a patient that has a ST elevation myocardial infarction. So with this, it helps us to be able to set time for these patients and they can receive a proper care. And we're talking about who is a flight nurse. A flight nurse is a registered nurse who specializes in the field of providing comprehensive pre-hospital, emergency critical care, and hospital care to a vast scope of patients. Registered nurse, you said the person must be a registered nurse first before you can be a flight nurse. And again, being a flight nurse doesn't mean that you have to do this only inside the aircraft. Your work starts from the hospital because you have to stabilize the patient from the hospital before you can move the patient into an aircraft. And again, another definition says that it's a nursing profession that is trained to provide medical care to a patient while they are transported to a medical facilities. This may include a life flight or a rescue flight. So it's either we use an helicopter or a fixed wing, which is known as a plane. So to have a medical crew, you can't just do a flight without having a complete crew. And the complete crew includes a critical care nurse, a physician, a respiratory technician, paramedics, and pilots. So what we do in aviation medicine, you have to work in synchronization with each other. Whatever decision that have to be made, it has to be made as a team. You cannot work as an individual. We do this in order to move the chain of care. Like I said before, there are some facilities which are actually not available in the rural area, which are available in urban area. So it helps us to move the patients to get adequate care that they require. It also provides an equitable and timely access to critical care medicine. That means whatever a rich person can access, a poor person can actually access it the same way. And also to bridge the clinical gap area existing at urban and the rural and regional level in regards to trauma, critical care, and advances in medicine and technology. We're still saying the same thing about the urban area and the rural area. And also moving a patient to a multi-specialist center. Also promote access to major tertiary and quaternary care hospital for coronary procedures and interventional radiology like angioembolism. Like I said, most of the patients we manage all kind of patients, but most of the patients we manage, which are red flag, a patient with subarachnoid hemorrhage and a patient with ST elevation, myocardial infarction. So those are the kind of patients that we manage, and this is the reason why we do medical retrieval system. And it's also because of the time interval between a particular region to a region. It's easy for the patient to get to their destination with the use of an aircraft. So talking about aviation medicine or aviation nursing, as a nurse, as Madam Kiran has introduced me, for you to be a flight nurse, you have to understand the aviation physiology. What do I mean by aviation physiology? The atmosphere itself of the earth. How does that affect our patients? We have
have different layers of atmosphere, and the Earth itself comprises of 5 layers of atmosphere. We have the troposphere, we have the stratosphere, we have the mesosphere, we have the ionosphere, and exosphere. What concerns us as an aviation nurse or aviation medical personnel, it's the troposphere because that is where we find our aircrafts. And we all know in the atmosphere we have various gases. We have nitrogen, we have oxygen, we have argon, we have carbon dioxide, water vapor, and the inert gases. And we know that oxygen is what is the air we breathe. We have 78% of nitrogen. We have
So what's kind of the gases in our atmosphere, they have four interdependent physical properties, which these properties have a very important activity or actions on our body, especially on the critical patients. The volume, the temperature, the pressure, and the mass. So why are we concerned about these four physical properties in aviation medicine? Like I said, they have effect on the critical patients. There are certain causes which may affect the general condition of the patient, especially the critical ones. Even as a group, some of these gases also affect us, but our focus is on the patients. We have the Boyle's law, we have the Charles law, we have many laws which actually govern the condition of our patients. So what does Boyle's law does? It reduces the effect of pressure on the body. For a fixed amount of an ideal gas kept at a fixed temperature, the pressure and the volume of the gas are inversely proportional. I know some people ask, why is it our concern to know about the gas? You have to know about the gas. You have to understand it. Because let me give you an example. You have a patient with a penetrating eye injury or a patient with abdominal surgery, recent abdominal surgery. And you know most of the abdominal surgery we use CO2 gas while we are doing the surgery, especially laparoscopy. And most of these patients may have a free gas present in a confined body cavity. And if this patient is taken to a high altitude, the volume of the free gas will expand. When you are on high altitude, the gas expands. And as the surrounding of the gas, the pressure is reduced. High altitude, reduced pressure, there is an expansion of gas. And it's also in direct opposite. When you have a low altitude, you have a high pressure, the gas will contract. So with this will actually lead to a further complication, which we don't want that to happen. You are managing a particular situation, and again you have an additional problem. So that is you shifting your attention from the main problem to another problem, which is actually going to cause a serious confusion in the plane. So we can see the patient might have an intraocular pressure, or they might have a difficult ventilation. Why? Because the gas keeps expanding and affecting the lungs. Also, there are other issues which require prompt intervention before we even move any patient at all. Let's say, for example, you have a patient that has a gas inside the intestine. What do you do before you leave such a patient? Before you move them? You have to put an orogastric or NG tube and open the vent so it can actually suck out the gas before you move the patient. Again, another case of a tension pneumothorax. You already know that's a critical care patient, which has to be on ventilator. And you have a tension pneumothorax. What do you do before you move a patient at all? You have to insert a chest tube to remove the air that might be trapped and relieve the pressure because you do not want a collapsed lung while you are on board. Then you have an expansion and contraction of the pneumatic splints of the extremity. For a patient that has fracture, we don't use a hair heel splints for such patients because with high pressure, the splint is going to be open and a lot of complication is going to arise. Then, I want to ask you a question, please. While we are doing intubation in the ICU and we input the endotracheal tube, normally what do we feel in that endotracheal tube in the ICU? Can someone just tell me? Hello?
This I shall continue. Continue.
Okay, ma'am. So in aviation medicine, we don't put air inside the endotracheal tube. We put normal saline inside to avoid the pressure in the balloon, because if we go on a higher altitude, that balloon is going to burst. And when it bursts, the patient is going to be having respiratory distress. So this is what we do while we are on board. So goes to the Charles law, it also acts of effect because it has effect on temperature. It's, for example, we have a cylinder on board. It tells you have to avoid putting your cylinder in a place, an oxygen cylinder, put it in a place whereby there is high temperature. Because if that happens, the cylinder also can actually cause a rupture in the aircraft, and that's a disaster. Same thing goes for the Dalton's law. If you have a COPD patient who has an oxygen saturation of 92 at sea level, which will require a supplementary oxygen at altitude, as the partial pressure of the oxygen in the environment decreases. So it is mandatory for a flight nurse to understand the principles of aviation physiology and its relationship with the patient's condition during medical evacuation. We have different patients that we evacuate. So before you move any patients, you have to study the case, understand the nature of the patient's sickness, and what are the interventions that you can make. Now I move to the primary survey and the resuscitation. It's the same thing we do in ICU, but in aviation medicine, you have a trauma patient. The first thing we look at is the circulation. You have to look at the perfusion system, look at the hemorrhage. You have to control the hemorrhage. If the patient has any obvious bleeding, you have to put that in order. Then you move to the airway, and with the cervical spine protection, the airway, what do you do? The same thing we do. You open the patient's mouth for any obvious secretion, bleeding from the mouth, or anything in the patient's mouth. Position the patient, remove all that. And we go to the breathing. You look at the patient. A trauma patient, you have to open the chest of the patient, open the neck of the patient to see if there's any bleeding. You have to look at the ventilation, look at the rising and the falling of the chest of the patient. If the patient requires any oxygen, if the patient is conscious or unconscious, you have to know that. In that case, you start your CPR. Then look at the disability. This is very important because the present care you give to the patient will determine the outcome in the future or later. It's not just about evacuating patients and dropping them at the hospital or where the destination, but also you have to prevent the further complication which might arise later. For example, you have a patient with subarachnoid hemorrhage. You are just particularly about just the airway or the breathing. What about the disability which will occur later? So you have to actually assess the patient neurological status by using the GCS score, or you use the AVPU to actually ascertain the level of consciousness of the patient, the exposure and the environment, and ethical decision making. The exposure, look at the surroundings of the patient. What do you think is the cause of the problem? If there is the cause of the problem, if it is still there, probably a chemical exposure or something, and you did not take care of that, while you're even ventilating the patient or you are managing the patient, you're still going to end up continuing the same problem until you remove the causative agent. And the secondary survey, we're still talking about what you can do for the patients later to make them feel better and restore them to normal health. So I move to the hypoxia. Hypoxia is a very, very important topic in aviation medicine, as it affects the crew, it also affects the patients. What is hypoxia? Hypoxia sometimes be incorrectly associated with just the flight altitude, but it can actually result from so many things, not just the altitude. We have different causes of hypoxia. We have the hypoxic hypoxia, which is an insufficient amount of oxygen on the red blood cells. We have lack of RBCs, which might be due to anemic hypoxia, or inability of the red cells to carry oxygen, which is ischemic blood. Issues with immobilization of RBC, that is stagnant blood transport, that is stagnant hypoxia. Inability of the tissue to use adequate supply of oxygen, that is histotoxics or cellular hypoxia. Okay, when we talk about this, we talk about the hypoxia, which is the major common hypoxia in the aviation medicine. In this case, we know that as we go to an high altitude, there is reduction in the gaseous exchange in the lungs, which is one of the reasons why most of the patients develop hypoxic lungs. So then we go to hypoxia at high altitude. Like I said before, when you are at the sea level, there's something we call the sea level. The sea level is when an aircraft is pressurized to the cabin pressure of the aircraft is pressurized to at sea level. That means about between 5,000 to 8,000 feet. So that still makes you feel you are on ground. So in this kind of situation, you will not feel any difference. Even most of patients do not feel any difference because most of the saturation levels still remain about 90% at the sea level. So in this case, there are some physiological responses which may occur. You might just see maybe some of them will have an increase in heart rate and the respiration will a little bit slightly go up and decrease in night vision. And there's a stage which we call the compensatory level. That is when the aircraft has climbed between the 10,000 and 15,000 feet. In this, you see that there's an increase in BP, the heart rate, and the respiratory rate. There is gradual impairment of efficiency and ability to perform tasks. This, I'm talking about the crew. As soon as you're climbing to this level, you start having some changes in your body, which it is normal to this extent. And when it's becoming disturbing, that is when you start seeing most of the patients, most of the crew start feeling dizzy, they have slow thinking, and you have a patient in front of you who is a critical patient. And you're slowly thinking, you have to be a fast thinker, you're feeling dizzy, you have a decreased muscle coordination, that is a disaster waiting to happen. Because the nurse obviously is going to become the patient. And at the critical level, that is when the aircraft is at 20,000 to 30,000 feet. Then you have confusion, you become incapacitated, and even to the level of losing of consciousness. So, to avoid all this, the American Association, they did a research, and they told all the crew, if you are going on a mission, make sure you have an adequate sleep, at least 12 hours sleep. And which is why even the Aviation Association, they told pilots they must have a 24 hours rest before going on any flight. Again, smoking, drinking alcohol, you are hungry, or probably you finish a flight at evacuation and you are asked to go on another evacuation. You never had any rest. So according to this, all these things can actually happen and can be pronounced to the level of criticality and making you incapacitated and lose consciousness. Imagine having a pilot who is confused and incapacitated. What do you think will happen? The aircraft is going to crash. So, as a team, you have to work hand in hand and be sure what you are going to put on the aircraft before you embark on any journey. So, I go to the transfer. What are the type of transfer that we have? We have a critical care transfer. That is a patient who is critically ill already in ICU. You are moving the patient from an ICU. So the kind of team I, as a flight nurse manager, am going to assign to these patients is going to be an intensive flight team. That means I'm going to have a respiratory technician on board. I'm going to have a critical care nurse on board. Probably,
and anesthetists if possible. Then we transport multiple patients. In my aircraft, we have 2 stretcher capacity. So I can put 2 patients on the aircraft and manage them. Then we have wing-to-wing transfer. What do we mean by wing-to-wing transfer? It's just like having a relationship with a commercial aircraft, say like Air India or Indigo here. We have a relationship with them, and I want them to move a patient probably from Agra to Delhi. I'm moving the patient from Delhi to Luton Airport in London. Why is this important for us to have a relationship with commercial aircraft? One, it saves time of us flying to the patient and coming back to Delhi to move the patient again. So with this relationship with the local airlines, it helps us to move the patient on time. It saves us costs as well. So what are the retrieval platforms we have? That means what are the things we use to move the patient? We have a fixed wing, we have a rotary, which is the helicopter, and we have road by using the ground ambulances. The fixed wing is same thing as the airplane. Looking at this, this is a 5 November Echo Mike Sierra. This is my aircraft. We have 2 stretcher on this aircraft, and the threshold of this aircraft is about 7 hours non-stop. And this is the internal part of the aircraft. So looking at the down part, you have the life force machine, which is attached to the stretcher. That is where the oxygen is. We have the suction attached to it. We have the oxygen attached to it. So many things are attached to it. Looking at the top here, this is where we put our monitors, our ventilators. Depends on the kind of patients that we have. This is a rotary wing, which is an helicopter. This is an helicopter. It can actually carry about 3 patients at the same time as well. So it depends on the location where you're moving the patients. You choose the kind of machine that you're going to use. You have a patient in a far local area, say maybe like in Balagga. In Balagga, there's no airport there. So while you're choosing, you definitely have to choose an helicopter which can land anywhere to move the patient. So, and this is a ground ambulance, which you have to have a link with whenever you are having to move your patients. So then, how do we prepare for a patient while you're using the helicopter? Like I said, most of the patients we use the helicopter for are more of trauma patients, a gunshot, you know, a war zone area. So before you go, you have to ask, what is the mechanism of the injury of this patient? What is the location and the time of the incident that happened? What is the hazard that is still going on in that area before you carry your crew and go there? Are the people shooting still around there? Is the environment safe for you to go? You have to ask all those questions before you move. How many numbers of patients are you moving? What is the age group? You have a pediatric patient there. Definitely you have to have a pediatrician on board with you. Is there any obvious injury? Is there any much trauma or hemorrhage? What kind of intervention has been performed before you land in that place? You have to oversee the area. Is there any landing area there? Like I said, as a nurse, you have to know how to calculate your landing area. You have to know how to calculate where you're going to land. You have to know the location that you are going to. Is there any wire there? Is there any pole there? You have to look at all that before you move. Through your navigational chart, you have to know how to read a navigational chart as a nurse, as a flight nurse. The patient transfer area, location where the transporting will find the patients. They don't want to tell you that a patient is in Sarojini Nagar. and you are going to Noida. Already you have wasted time in going to Noida. So you have to know the exact location where the patient is. What are the need for additional personnel? Do you need any other personnel on board? Do you need a physician on board? Do you need a respiratory therapist on board? And the kind of equipment you want to carry. You're not just going to carry all kind of equipment, because the weight of the aircraft also matters. You have to calculate the weight of the aircraft, the weight of the stretcher you are going to put, how many people are going with you, the oxygen you are going to carry, the medical equipment, all those things you have to put them into consideration before you go. So these are generic retrieval process. Patient referral might be an hospital, might be a patient's relative. You have to coordinate the case. Like I said, what kind of aircraft response are you going to use? Are you going to use the airplane? Are you going to use the helicopter? Selecting your crew, the safety of your crew, the equipment that you're going to use, all that has to be put into consideration. So now, what are the role of a flight nurse manager? I'm the flight nurse manager for my agency. What do I do? The call usually comes to me. I coordinate most of the flights that I do. I get a referral, a call from the referral. So what is my advice? What is the transport plan? What is the update on the patient's current situation? Where is the location of the patient? Is the patient in the hospital, or is just an open place? Who is going to be responsible for making the decision on giving me the information I require concerning these patients? The medical report of the patient, the blood work that has been done. Is the patient on oxygen, or is he on ventilator? What are the treatment that has been given to the patient? What are the underlying medical conditions? Is there any chronic illness? Is there any infection? All that we need to ask before making a move. After receiving this, I will talk to my team. The task that is available. What is the urgency of this task? Is the patient a subarachnoid hemorrhage patient, or is he ischemic attack? What is the patient's condition? Based on that, I'm going to make a response. My response usually takes between an hour, 30 minutes to 1 hour of receiving a call. I have to make activation. I select the team that I'm going with. Importantly, you have to give briefing to your team. We do briefing before moving the patient while receiving the call. We do briefing before moving to the airport. We do briefing at the foot of the aircraft. We do briefing while we get to the patient. What are the things we are going to do for this patient? And on arrival and delivering the patient, we do briefing as well to know what mistake we have made, what are the things we need to do to enhance our activities, our performance for the future patients. So then I give updates. I have to look at the time of arrival. I have to coordinate with the receiving hospital, because you do not want to carry a patient from Delhi. Let's say you want to carry a patient from Balagha, and AIIMS already inform you there's no bed, and you are moving a patient to AIIMS. How are you going to do? Are you going to go back? Or where will you take the patient to? So it is important to have a proper coordination with the receiving hospital as well. Take for example, I received a call to move a patient from National Hospital in Abuja to another country, in a nearby country, Niamey. And on getting to Niamey, the doctor approached us. They are French-speaking country. We don't understand French. We have difficulty in communication with the doctor. And again, while the doctor saw the patient, he told me, "I'm sorry, I thought the patient was on oxygen. I was not informed that the patient is on ventilator. We don't have a ventilator in my hospital." This is a disaster. So what do? We have to come as a team. As the flight loss manager, I have to call, make the shots. And I told the pilot, we have to move this patient back to Nigeria. Coordinate with the patient's relation. Do you have any other hospital you're taking the patient to? Because they move the patients on Lama against medical advice. So the referral hospital are not going to receive the patients again. So according to that, the family made a decision and we moved the patient to a private hospital. So if peradventure, we have actually confirmed from the family if they had made a proper arrangement, which I asked, but the son just wanted to move the patient by all means and agreed they are expecting the patient. Hospital confirmed they are expecting the patient, but the condition of the patient was not properly informed. So getting there was a disaster. So which is why I'm still going to talk about oxygen calculation, because while leaving, I had to carry extra oxygen. We all know a patient that is on ventilator consumes more oxygen. So I take extra oxygen, which helped me in returning the patient back to Nigeria safely. So from this, I moved to the phases of coordination. When you get a call, as I've explained before, you open the case, you get the clinical details, the location, what are the resources that are available at the place, what is the size of the patient, what is the weight, who are the people coming with the patient, make a decision. What are the clinical management that have to provide to the patient, the urgency, is it a complicated case, is it a multiple trauma patient? Then I pick my crew, who is going to accompany me. What are the platform I'm going to use? Am I going to use an helicopter? Am I going to use a fixed wing? The destination I'm going to, what is the duration? I have to put that in mind. I have to calculate. Communicate with my crew. I have to communicate with the receiving facility. The referral facility, like I said, I have to coordinate with them too. I have to keep case track. I have to receive the updates of what they have done for the patient. I have to provide updates on what I did on board also while moving the patients. Also, after I close the case, I receive the feedback from the client, and also I provide feedback to the receiving the referral hospital. So, what are the common coordination problems that we can have? As much as we usually have problems in our day-to-day activities, even in the hospitals, we also have common coordination problems also. So what are these coordination problems? The air platform, do we have, is it available? Look at the weather condition. You do not want to send your crew on a bad weather. For example, while I was in America for my training, there was a call for the crew to move a patient in North Carolina. The weather was bad, but because it is an insurance patient and they are one of the sponsors of this organization, so they couldn't turn down the offer. They have to go. They picked the patient on their way back, the aircraft crashed, the helicopter crashed. They lost all their crew. So sometimes we have to put sentiments apart. You have to make the right decision for your team. You have to make the right decision for your team. Link with the tower. Be sure the weather is favorable. If you're already on a mission, inform them you're on a mission. Before and on arrival, make sure your crew rests, or you select another crew to go for this mission. Again, communication problem, like I said. We are English-speaking nation, and the other country, they are French-speaking nation. How do we communicate with these people? So you have to have someone who can be an interpreter, so you can get the correct and adequate information from the referral. Again, there's language barrier, which is the same thing as communication issue. The crew fatigue, like I said before, it is important for you to have an adequate rest. Eat properly before you go on another mission. If this does not happen, then it's a disaster waiting to happen. Your patient is going to suffer, you're also going to suffer. So then, there's sometimes we have conflict with referral. It's a common thing that happens. I actually had an encounter in the same situation. I went to Malta to evacuate a patient. I want to move the patient to England. And on getting there, they were holding information from us. They were telling us we cannot move the patient because the patient is he is a government official. So they feel it is their responsibility to take care of the patient. They don't want him to go. So with all this information, what are you going to do? If you don't have information, it's difficult for you to manage such a patient. Why? You don't know what you're going to meet. Even in aviation medicine, we always prepare ahead of issues that might arise. For a patient to call for you to come move them, you know that that's a critical patient. That is a patient that is very, very sick. So you have to anticipate anything can happen in this kind of issue, you know. So refusal to perform intervention which are advised by the coordinator. For example, while we were leaving Nigeria, I had another patient in an African nation, and on getting there, we told them beforehand when we saw the medical reports, which was not even in detail, can you please intubate this patient before we come? So it's going to save our time. They said, no, they're not going to do that. While getting there, there was an issue. They do not want to release the patient to us. And there are some medical things, there are some legal issues that bind you in a different nation that you're going to. You have to be careful what you can do and what you cannot do. In some countries, a nurse cannot intubate a patient. These trends are changing recently. So if you go as a nurse to go to a nation where they don't intubate a patient, what are you going to do? They can arrest you. You can be in trouble. So which is why sometimes you need to carry a physician or a respiratory therapist or technician who is permitted to do such a thing. And again, in a situation whereby you're not using a private aircraft, like my company, this is a registered air ambulance in Nigeria. Even if I land on any soil of a nation and I'm inside that aircraft, I am in Nigeria. So my license permits me to do what I cannot do inside the hospital in my aircraft with the consent of the patient's relation. So what I did, I moved the patient from the hospital since they were having issues with us. They were fighting with us. I moved the patient into the aircraft and I intubated the patient and we moved the patient to England. It was a successful mission. So then, some receiving hospital, like I said before, not confirming the availability of the bed space or acceptability of the patients. That's a problem because you'll be left to, is either you take the patient back to where you're moving the patient from. That is going to cost you a lot. Is the patient going to pay you for the returning leg? You are going to pay for your crew. Probably you want your crew to go there and come back the same day. Probably maybe it's just about 3 hours journey, and you want to return back to your country the same day. That won't be possible. That means you have to lodge your crew in an hotel. You have to pay for that. You have to pay for fueling. You have to pay for landing charges. You have to pay for overflight. So as a flight nurse, you have to put all those things into consideration because it's going to be a loss to your organization. So checklist. Checklist is very, very important. Very, very important. I know we do that in the hospitals too. We call that inventory. But this is a different one because a checklist is actually very, very important. A checklist is an aid used to reduce human error and improve a person's ability to reliably complete a series of tasks by compensating for limitations of attention and memory. Okay, we have different types of checklists. You have a call-taking checklist. It ensures that a critical information required for your planning, like I said, vital signs of the patient, the present vital signs. You do not want to receive a yesterday vital signs. compared to today, probably the case of the patient might have become worsened. The patient might not be stable anymore. While you're getting there, you meet a different scenario. Then you'll be thrown into to worry. How are you going to manage this? Because you did not carry all the required equipment for a patient. With you have a patient that they said, oh, the patient has a cerebral malaria. All right, and you got there, it was a different thing entirely. Or you have a patient with dengue fever, and again the patient is already having hemorrhage. You do not know about that. The condition has worsened as compared to the last vitals checked. And weight of the patient, like I said, for you to manage that, to fly a patient in an aircraft, you have to look at the weight of the patient. If you have an obese patient, we have different types of aircraft to use. Is either you use an helicopter, which is easier because the doors are wide open to put in an obese patient, or you prepare yourself using a life pot loader to load the patient. If you have a normal patient, say maybe about 60 kg, you can easily move the patient with a vacuum mattress. But you have a patient above 120 kg, you can only use a life pot machine, the raft. You load it and you move the patient. It has a slide to slide the patient into the aircraft. It saves you your strength, and it saves the time on lifting the patient. Then the equipment checklist. It is your duty as a flight nurse to check your equipment. Ensure that you carry all the essential items and kits, and ensure that they are in working condition. You do not want to carry a ventilator. I use an Oxylock 3000 plus dragger, and the battery is not well charged, and you do not have an extra battery, and you have already journeyed about 7 hours in your aircraft, and you meet the patient, and your ventilator is not working. That's a failed mission already. You wouldn't want that to happen. Before departing, you do a departure checklist again. It is important. But sometimes all that is, you usually overlook it. Are you sure the patient you are carrying is the right patient? Did you check the wristband in the patient's hand? You do not want to carry a different patient, and you reach your destination and realize it's a different patient you carried. Then it's also a failed mission, because nobody's going to pay you for that. The clinical checklist. Sometimes in the hospital, we have some checklists that we follow while intubating a patient, or while diluting a drug, or while giving an injection. What are the compatibility of drugs? That kind of a thing also we do it. You have an obese patient and a normal patient. The way you're going to intubate the patient, you can use a normal laryngoscope to intubate a normal patient. But what about an obese patient? You have to use an LNA, a different one entirely. Or you need to use a video guide intubating machine to intubate such patients. So that is the part of the checklist. So what are the duties of a flight nurse? The pre, the intra, the post-medevac mission. Like I said before, you do team briefing. You assess the mission based on your own, based on your judgment. How do you think the patient is? The medical report, is it going to support? Are you sure the medical report is in order? Can you work with such reports? Based on this, you decide with your team, are we accepting this mission? The mission, then you go ahead. Based on a team decision. Then, some patients who are in your locality, say maybe you are in Delhi and you have a patient in Safdarjung Hospital, you can actually go to the Safdarjung Hospital, you do your pre-hospital assessment of the patient. So you know the kind of patient you're going to deal with a day before or some hours before you go and move the patient. Again, we have a standard operating policy, which is a guideline we follow in aviation, nursing, or medicine. You have to be thorough with your standard operation policy. For example, you have a patient with subarachnoid hemorrhage, and they ask you to come and move the patient 3 days after the issue has happened. No, that is not right. It is advisable to move a patient with subarachnoid hemorrhage within 24 hours that it happened, because between the third day and the 14th day, that patient might become practically unstable, and anything can happen. You have a patient that is not stable, he has a bleeding inside the brain, the pressure is increasing in the brain, and you're also flying the patient also at the same high altitude. You have to be careful. So it's important to understand your policy properly. The type of transfer you do, is it a wing-to-wing transfer you want to do? Liaise with the referrer and the recipient ground ambulance. That's another problem that we usually overlook. The hospital says they are giving you a patient to come and evacuate. Are they the one that will bring the patient to the airport for you? Or do you have to go to bring the patient yourself? And again, recipient ground ambulance. This happened in France. I flew a patient to France. Unfortunately, it was their Republic Day. Nobody was working. I spoke with the patient's relation, the daughter. She told us that, oh, they have a ground ambulance waiting for them. Again, they are sure they have a ground ambulance based on their communication with the hospital. Unfortunately, while we land at the airport, there was no ambulance waiting for the patient. So sometimes you have to take charge. Do not allow the patient's relation to make that decision for you that, oh, we have a ground ambulance waiting for you. Sometimes it might not be true. So you have to be on top of your game. You have to communicate with them. Again, before you move any patients, make sure they sign an AIIMS consent form. Any patient that have been sent to you to be moved or to be evacuated, be certain such patients are critical and anything can happen. Nobody wants to lose their family, no matter how they know the patient is very sick, or they might even not survive it. But if you did not allow them to sign an AIIMS consent form, they are going to drag you. They are going to use a legal issue against you, which you do not want that. So you have to make sure they sign the consent form before you move the patient, that anything can happen on board. So they are aware that this kind of a thing is possible, that it could happen. What is the visa status of the patient and family? You don't want to enter immigration problem. Is the patient having their visa? Is the family having their visa? You have to be sure. You don't want to move a patient to a country where they don't have visa, and you are in problem. Your aircraft is going to be in trouble. So you have to be sure the visa status is intact for the patient and for the family. Then, checklist of the equipment, as I said before. You have to know if the case you are handling is it a critical or non-critical case. If it's a non-critical case, there are some luggages or some equipment that you do not need to carry. Then you are sure it's not a non-critical case. So you will not want to overload your aircraft. Again, there are some families that they will tell you they have 5 people that want to come with you. No. Standard, you can only have maximum 2 relations or 1 relation. Maximum 2 to accompany you. Maximum 2, not more than that. You have to consider the weight of the aircraft. Then loading and offloading process. You have to be thorough with how you load your patients. The way we load the patients on an helicopter is different from how we load the patients on a fixed wing, on airplane. Because you're loading a patient in an helicopter and the blade is rolling, the rotor is rolling. You have to understand that safety precaution on how to load your patients. You have to understand that. You have a patient with ventilator tubings, you have the patient with monitor tubings, you have the patient with IABP monitoring. How are you going to secure that? We have a bag that you can put your ventilator in. Strap it at your back while you move your patients. You have to coordinate. The process of coordination is very important. Because when your tube comes out, you know that's a problem waiting to happen. So you have to go back to square one again. You have to reintegrate the patient. That is a waste of time. In that process, you could actually lose the patient. So it is important to understand how you load and upload your patients. The kind of equipment we have on board, we have transport monitor, we have ventilators, we have defibrillator, we have vacuum mattress, which we use to move the patients. We have a scooper that you can use to move, especially a patient with spinal injury. It helps the patient to be immobile. You have infusion pumps, you have a life port, like I showed you the picture of the life port before with oxygen. You have a suction machine, you have a thermal blanket. A thermal blanket, preferably a disposable one, you use that because at the high altitude, you realize the patient feels more cold. Inside the aircraft, the temperature also, it's cold inside the aircraft. You understand? So with that, you have to manage the temperature of your patients by using a thermal blanket. You have consumables and disposables. You have your IV infusions. You have a catheter to catheterize the patient. You have so many other things, neck collars and all that. Based on the case that you are doing, that's how you carry your consumables and disposables. The critical retrieval bag, that has it's mainly for a critical patient. You have a patient that you need to monitor the IABP. You have a patient that you need to do. You have airway that you need to manage the airway of the patient. Hemodynamic monitoring. So many things like that are to be found in your bag. So as a nurse, as a flight nurse, it is important that you arrange your bag according to patients that you are carrying. Arrange your bag according to the patients you are carrying. If you have depleted any items, you replace them back. It is your duty. If a mission fails, the blame is usually on the flight nurse. You have your airway bag, you have so many things that you need to carry. You select and carry the emergency drug bag. The drug you are carrying, you have to understand the usage of the drug that you are carrying. There are some countries that you cannot administer some drugs as well. You have to understand that as well before you move. So based on that, you have to select your crew properly. You manage your patients accordingly. Oxygen calculation, like I said, you have to calculate the oxygen required for the journey. All right. You're going to Dubai. From Nigeria to Dubai is about 7 hours journey. 6.5 hour maximum, but if the weather is not favorable, you're going to do about 7 hours. So are you going to carry an oxygen that is going to be enough for you for 7 hours? No, you have to carry extra because anything can happen on the journey. Be on top of the situation. You are on your own. A pilot cannot help you. An engineer cannot help you in the aircraft. You are on your own. You have to make your decision on your own. You lose the patient, it is your responsibility. You deliver the patient safely, it is your responsibility. You have to be on top of the situation. No matter the situation, you have to be on top of it. So you have to coordinate with the pilots too. That's why we say we have crew relationship. A pilot should understand what is going on in the cabin. You have a patient, again, with subarachnoid hemorrhage. There is pressure in the brain. All right? And again, ICP is there. And you have to tell the pilot, I need you to reduce the cabin pressure. I need you to increase the cabin pressure. Why? Because the patients you are having cannot manage in this pressurized cabin. You have to reduce it. And again, the temperature of the patient. You have to coordinate with the pilots. You are together, you are a team. Please reduce the temperature of the cabin. Reduce the temperature. Accordingly, you communicate what is going on. Accordingly. So everybody will be on the same page. You have to find out the medical legal situation in the country you are going to. Again, you are a nurse, you finish your trip, you've handed over the patients, and you are in Saudi Arabia, and you're wearing a tight skinny jean or a tight screening dress. You can't do that. You have to understand the law of the country. Except you're just going to be within the airport. But if you're going into the town, you do not want to put yourself in trouble. You do not want to be harassed. So you have to understand the legal situation where you are going to, concerning the medication administration, concerning the intubation and all that you have to understand. Then you have to document the care that you were given, you actually give the patient on board. Documentation is paramount. Same as what we do inside in the hospital. You have to document whatever that you do. Whatever that they do at the referral hospital, have the copy of it. In case something goes wrong or a dose is being missed before you move the patient, you know where the issue actually comes from. And on ground, when you're doing handover, you have to hand over to the receiving team. You have to know the situation, what you did on board. You have to inform them the background of the patient. Where you move, where you carry the patient, you have to inform them assessments that you did, your recommendation of the equipment, your recommendation that you gave, the kind of equipment that you gave, you have the kind of equipment that you use, the injections, the treatment you gave the patient, you have to brief the receiving team. You are in charge of care of your equipment. We don't reuse most of the equipment that we use, especially the corrugated TVs. We use disposable ones, we don't reuse. Most of the items are disposables. Waste disposal, how are you going to dispose your waste? You don't want to expose your crew or yourself to an infection. How do you disinfect your aircraft? It is the work of the flight nurse to do all that. You have to disinfect your aircraft. Each use you have to disinfect it. So that much is what we do. So these are the equipment that we use on the aircraft. Behind me is my critical bag. It's written there. This is my monitor. This is my suction machine. This is my life port machine. This is my life port bed. There's oxygen attached in it. I have my ventilator bags inside. Depends on the kind of patient I'm moving. That is how I select my items. So, like I said, this is a patient that I was actually evacuating this patient to Dubai. And this is the nurse that accompanied the patient from the hospital. She was giving me the brief of what was done in the hospital, the treatment they have given the patient, the ongoing treatment, and everything that I need to know about the patient, and ensure the family sign an AIIMS consent. That is my, on the ground there, that is my vacuum mattress, which I use in moving the patient. Some of the patients, we put this vacuum mattress on the stretcher before moving the patient, but this is a fractured, the multiple fractured patients. You do not want to manipulate the patient by putting them on the stretcher and then now move them again. So we put them directly on the vacuum mattress and we move them directly inside the aircraft. This is me, in-flight care management. This is an anesthetist with me on board. This is a critical patient who is on ventilator. We are bagging the patients here. That is the relation. Like I said, we have just two relations that has to accompany the patients. So this is a two crew medivac. So that is the patient there. This is a arrival in Dubai. You can see the Dubai team here. We're giving them the briefing of what has been done on the aircraft. So I gave them the handing over of the patient. Sometimes some of them will ask you to accompany them to the hospital, while some of them will just take over the patient and go. So it depends on the situation of the patient and depends on the items that they have in the ambulance. You wouldn't bring an evacuate a ventilated patient from a long distance and they bring an ambulance that doesn't have a ventilator. So meaning you as a flight nurse, you have to accompany them to the hospital with your ventilator. It's a decision you have to make because the patient could die on the way without a ventilator. So this is me briefing the receiving patient, post-flight briefing, the receiving hospital in Luton Airport of a patient that we evacuated what and what has to be done while we are on routing to the hospital. So now coming to the oxygen calculation, it is important to reiterate that the whole mission will be from hospital bed to hospital bed, not just the duration of the flight. Like I said, sometimes you have to go to the hospital and carry the patient, and you are using the oxygen that you're going to use inside your aircraft. So you have to understand the volume of the oxygen has reduced already. You have to understand that. So you have to be calculating. And it's advisable while you are carrying a patient, there might be a delay. Like I said, in Miami, the doctor came and he said they cannot receive the patient who is on ventilator. So there is a delay already dragging. If we have to drop the patient or we have to carry the patient along. So there are some unforeseen delay that could happen, which you have to be proactive as a nurse about it. So in practice, it's advisable that you carry 50 to 100% extra oxygen than the calculated requirements that you have based on the patient's consumption. Understand that if a patient is receiving about 4 liters per minute of oxygen before, at a high altitude, it increases. So probably you have to put it about 6 or 7 liters until the patient stabilizes at a particular altitude. So as you are climbing each altitude, you have to either increase the oxygen, and as you are descending altitude, you reduce the oxygen with the help of your SpO2, oxygen saturation, and that is how you do that. And again, now it comes to the calculation. So I have a patient that requires 40% of FiO2 using a red venturi valve, and the patient uses about 8 liters per minute, and my mission is about 3 hours. Say I'm going from Delhi to Bombay. So the oxygen consumption of that patient always converts the hours into minutes while you are doing your calculation. So I'll say my patient will receive 8 liters of oxygen times 3 hours times 3 times 60. That is, I've converted the hours to minutes by multiplying it by 60. So I have 1,440 liters of oxygen, which is the standard I have to carry based on this patient condition. But I have to add a 50% reserve, which actually is going to bring the total oxygen to a minimum of, I'm sorry, this is 1,440 times 1.5. Sorry, this has to be 1.5, which is the standard. So I have about 2,160 liters of oxygen. So even if I get to my destination, there is a delay, or I have to return the patient back to where I'm coming from, I know that I have enough oxygen to manage this patient. The same thing goes for the calculations with a ventilator. Patient with ventilator receive more oxygen. You have to anticipate that before you move. So now I will come to the documentation part. This is NEMA Special Air Operation Unit transfer document. As you can see, the file number of the patient, I have to put it there. The surname, the name of the patient, the escort, is a nurse going or is he a doctor that is going with the patient, address of the patient, the referral hospital, the doctor that is treating the patient, next of kin of the patient, relationship of the next of kin and the telephone number, the location where I'm picking the patient up, the destination of the patient, the departure date and the departure time. Consider the time zone. Right now, in Nigeria, we are around about 12 o'clock now, and over there in India, you're already around 4 p.m. So you have to calculate your time zone. Also, because of the drugs or the injections that you're going to give to the patient, you have to understand that. So you're not going to miss a dose or overload the dose of the patient. The date of arrival, the time of the arrival. Do you have a transit? Say I'm going to America or I'm going to Dubai. I'm going to Dubai, I have to stop in Saudi Arabia. to top up my fuel to refuel the aircraft before getting to Dubai. So while we stopped there, how many hours did we stay there? How many minutes did we stay there? That I have to calculate. The diagnosis of the patient, what is the current problem, history of the patient, a brief history, what are the investigations that were done, the treatment that was given by the hospital, does the patient have any allergy reaction, then the current medication the patient is on. The pre-flight assessment, like I said, you have to do a pre-flight assessment by going to see the patient. So you will know the kind of patient that you are managing. It is your duty to certify the patient if the patient, he or she is fit to fly. And you have to write out what reason you think the patient is fit to fly. Then the observation that you made on board, what are the cabin altitude? Like I said, you have to put it. The oxygen you give the patient, the vitals that you recorded, everything has to be there. You do not want to go and carry a patient that is already moribund. You have to assess the patient, do the GCS scale, see the pupillary reaction, the reactiveness. You have to check everything before you move the patient. The inputs and outputs for a patient who is a CKD patient, you have to check the inputs and outputs and all that. So while you are doing your intervention on board, the time that you are set the handover of the patient, you have to write it. The vitals, the drug that was given, the last drug that was given at that time, you have to write it there. The departure from hospital, did you go and move the patient from the hospital? If it is, you have to write the time that you depart from the hospital to the airport. You have to look at the time you take off. The vitals, everything has to be recorded. The time you landed, all the drugs you given, the infusion, you have to write them. The landing, you have to put it there. The time you land is different from the time you arrive at your destination. Destination handover completed, at what time did you complete it? Whatever you do, how the patient was, do a post-flight assessment again. You do not want to be lied on that you gave them a patient that is dead or something. No, you have to do a post-flight assessment with the receiving crew, so they will know that you give them a live patient, and this was the condition of the patient. You do your transfer summary, you do the routing of the flights, you have to write it from Hyderabad to Delhi, from Delhi to Luton. You have to do that. Again, you have to put the patient passport number and everything. You, as the nurse that you escort the patient, you have to write your name in full, you have to sign, and you have to put the dates. So this comes to the end of my presentation. And again, when we talk about crew and talk about the altitude and the hypoxia of the patient, of the crew, you have to understand that it affects you, because there are sometimes you need to evacuate yourself out of the aircraft. If you are unconscious or you are hypoxic, then you will not be able to rescue yourself, talk less of to rescue your patients. So it is important to follow the safety procedure. Do not drink before flight, do not smoke, have a good rest, eat well, and all that is going to help us to have a successful evacuation. The aviation medicine or aviation nursing is a very vast topic. So this is just having a basic of what I do on the aircraft. So thank you very much for listening. Thank you so much.
Thank you, Aisha. It was a very, very elaborate, comprehensive presentation. We felt that we were traveling along with you in the flight. You have also explained the type of transfers you do, how we need to be careful, including the time zone we need to keep in mind, and everything you have explained, how proactive we have to be, how the planning has to be done, how to manage the emergencies, and it was a very good, detailed, complete presentation, I would say. And throughout, your voice was very stable, and you were very confident and explained it beautifully. Thank you so much. We really enjoyed your presentation. And we need to attend any questions from the audience. So let us see the chat box for the questions. Any questions? The delegates, you can post your questions, or you can unmute yourself and speak also. You can interact with the speaker.
Next question. Yeah. Congratulations, Babaji.
Congratulations, Babaji.
Yes, yes.
It was a wonderful presentation. It was a wonderful presentation. I think you have explained everything. I think we almost attended a half course of it. You explained each part of it. But can you guide some of the, some of the participants even asked, raised a question. Can you guide some of our participants if they are willing how to become an aviation nurse? How can they get trained? You can guide them. Can you guide them
Yeah.
briefly?
Career opportunity as
Okay.
a flight nurse. Many, I think after listening to many are inspired to
Yeah.
become aviation nurses.
Many are asking, is there any aviation nursing in India, flight nursing in India? I think some of them may be interested, and this is also being live in YouTube. It will be available for future also, so you can guide them. How can they make their career as a flight nurse?
Okay, thank you, sir. Being a flight nurse, like I said, you have to have the background of, you have to have your BSc, nursing, and advisedly, you have to be a critical care nurse, which will put you on the edge because while you work in such an environment, you have gathered how to manage patients, you have the skill of intubation and all that, which a normal nurse working probably maybe in an endoscopic unit cannot do. And like I said, I started my journey from AIIMS, India. Thank you so much. You've given us the best background again. I'm really, really grateful for this. I'm really, really grateful. And I did my diploma in aviation medicine, Then I went to the US. I did advanced trauma course and did the exam there and have my CFRN certification. And I went to UK. I did training with the CCAT Foundation, which if anybody wants to be a flight nurse, I'm going to recommend him to train whoever that wants to be a flight nurse. He goes all over the world. He can travel to India to train whoever that wants to be a flight nurse. It's actually very expensive to do. Yeah, it is. I spend a lot of money. So it's something that you have to be prepared for. You know, later in the future, you're going to make a lot of money. And you're not just the money, the joy that you derive is saving life. And the confidence that you have while doing that. I could say when I started, I was just a normal nurse. And at the end of the day, I could compete anywhere. So people call me a doctor because of what I do. Yeah, like I said, if you're on board, you are on your own. You have to make the right decision. Nurse, it's a passionate work, it's a passionate job, it's a passionate career. We do not like to lose a patient. So you wouldn't want to lose any patients. So you have to be prepared for that. You have to be ready to do that. So in UK, you can actually go for the aviation course as well in UK. And the fixed wing training is actually different from an helicopter training. And again, you have your advanced training also in the UK. So it's a process. You have to follow each process. So to have a basic training, I would suggest you can actually reach out to CCAT Aeromedical Foundation, which is in the UK, etc. And they liaise with, they are affiliated with the University of Surrey in England. So Dr. Terry Martin can actually come to India on request. With me, we can actually make it happen. Thank you.
Oh, very good. Yeah. And I have a question. Are surgeries done in the flight? Surgeries?
Yes.
Surgical setup?
Surgeries are done. Surgeries are done. Okay,
Emergency
like I said,
surgeries or planned surgeries? Elective surgeries are also done?
sometimes it's not. Sometimes it's not planned. It's just that you have you carry a patient who is a pregnant mother who is not fully tame, and because of the altitude and because of the patient probably had a trauma or a gunshot. So what you have to do at that situation, and the patient is in contraction in labor, you have to do a cesarean section if you cannot perform a normal delivery, considering the condition of the patient. And again, certain procedures are done too. You have a patient with a tension pneumothorax. You have to put the tube, intercostal tube, you have to put the tube in the patient. You have to do all that. Those are the skills I learned while I was in America during my training. So, and sometimes we usually try to avoid doing that on board. If you have a cooperative referrer, a cooperated one, you can ask them to do the procedure before you go and pick up the patient. Like I said, they might agree with you, and some will not agree with you. So it depends on the situation that you find yourself. But when you find yourself in such a situation, I've accompanied a flight whereby a kidney transplant was done in the aircraft.
Great.
Yes.
Yeah, that's great.
So the medicine is actually going to a greater dimension now compared to what we've known in the past. So it can be done.
Oh, correct. And how do you manage the language difficulties, like when you fly a person from one country to other country? So, how do you communicate with them in case if they do not know English? How are you managing the language difficulties?
Okay, ma'am, thank you. As an aviator, each destination you are going to, we have a ground handler, the people that are representing us in that country. Each aircraft that comes into a country, they must have a ground handler. Among them, there must be someone that understands both language.
Okay.
So most of the time, they usually help us to interpret and communicate with the referral hospital or the recipient hospital. And also, sometimes we use Google Translate
Yes.
to help us. It's fun,
Yes.
but it has actually helped in some ways.
Uh-huh.
So then I have a cabin crew in my organization who speak French. So since we had the issue the other time, so sometimes we actually go with her to a French-speaking nation
Okay.
to ease our communication, to ease the communication.
So you have network when you are flying. Inside the flight also the network will be there to use Google Translate?
No. I mean, when we land, it's on landing.
Acha.
Is that where we are picking the patients up or where we are landing?
So in
Sometimes
between,
you have network.
no, in between
Sometimes
inside
you
the
don't.
flight, if you need to communicate to the patient, then how will you manage?
The patients inside the aircraft, sometimes you have a relation, which is one reason why we carry some of the relation. They can help us to communicate with the patients. And most of the patients we evacuate, they are unconscious patients
Okay.
on ventilator.
Okay.
Even though as in nursing, you still have to communicate before you touch a patient, even when they're not hearing what you're saying. As we know that the hearing is the last sense organ that lost. So even the patient is unconscious, they still hear us. So we still talk to the patient, okay, I want to do this for you, I want to take this, I want to do this. So we still communicate.
Okay.
So that's how we do it.
Yeah. What are the legal problems associated with this transportation? Like the law is different between the countries, no? So have you come across any
Yes.
such legal issues?
Yes, there was a time that like I said, we had a crew who accompanied me on the aircraft. She's new, and the law that actually affected her was indecent dressing. When you go to a country, you have to respect the culture, you have to respect the law, you have to respect everything. So, and because I usually oversee some things, if I know that in a particular country, a nurse is not supposed to intubate or to give a particular injection, I go with a physician, I go with a doctor, possibly an anesthetist, which I know they are actually entitled to do so many things. So that is how we manage the situation. And again, these are issues.
Yes.
There was a time with my patient, he's an Italian citizen, but wants to go to Switzerland to receive a medical care. And he wasn't having his passport with him. And the brother said the passport is with him. But while getting there, we had an issue because the passport was nowhere to be found. So we had to talk to the immigration office in Nigeria and communicate with them over there. So they were able to check his background and realize he's a European citizen. So that was how we were able to move the patient there.
So I think we will have very many questions because this is a new area and everyone
Yes.
Wish that it happens in India too. Of course, many hospitals have got helipads now. They are flying patients, and organ transplant is becoming very increased what is it? The number of organ transplants are increasing in India. Many hospitals are doing multi-organ transplants, so the organs are flying from one part of the country to the other part. I think there is a lot of scope here, and probably in India also we must be having these kind of nurses. Probably we have not called them as aviation nurses, or we have not identified it as a discipline of aviation nursing. So I hope in future this discipline will develop in India too. We have a lot of opportunities, scope, and resources to develop this course. Thank you very much.
Thank you so much.
Any questions? So thank you very much, Aisha, for such a new topic and enlightening us with so much of knowledge, the legal issues, and so many other problems we face. Uh, I really, I really want to thank you a lot, and also I want to thank my principal, ma'am, Dr. Lata Venkatesh, who gave me this opportunity to conduct this Alumni Speak #2 webinar. So thank you very much. Thank you, everyone. And uh, I would like to thank all the studio staff because without their support, it was not possible. Especially all the technical staff, Mr. Susan, and moreover, my colleague, Dr. Muthu, because without his help, it was not possible for me to conduct and organize this webinar. So thank you very much, and thank you all the participants for your patience listening and participating. Thanks a lot. And once you fill up the feedback form, then only you'll be able to get the e-certificate.
Yes. And Aisha, any of your classmates have joined here? Anyone who can say?
I think so. I think I saw Tarika some minutes ago.
Yeah.
Yeah, Tarika Sharma. Yeah. I think some of them they were on board. They were there.
Yeah.
They've been calling me though. We've been chatting. We've been talking, and they were really.
They can say a few words about you, how you were when you were a student in India, in AIIMS. Tarika, are you there?
Tarika is the classmate. Okay, she's in ILBS, I think.
Tarika is in ILBS. Ambili was your classmate, I think.
Ambili was my classmate, yes. Ambili was my classmate.
Must be knowing Muthu.
You know Muthu then? No.
No, I was doing MSc.
I know, he's only thought that. No, I know him. Namaste, sir.
Yes.
I know him.
Yes.
Yeah.
Any of the delegates want to speak?
Too?
Yeah.
Anyway, it was wonderful experience to have you here today. And
thank you so much, sir.
I think we should continue this association. You can help us in designing a short-term course in aviation nursing. And we can have a course for a week or 2 weeks. You can give us more resource persons, connect us with the resource persons who can help us in teaching. You know, we can design a short-term course.
Yeah.
And
Okay, ma'am.
It is required, I think. We need to
Faculty
structure
exchange
this.
program.
Yeah.
Yes, it is
Yeah.
important. It is
Muthu is
important.
asking for faculty exchange program. So will you allow him inside your flight if he wants to visit?
Why not? You're
Yes.
welcome.
Great. We will facilitate that. Yeah, great idea. See, I think.
Yeah, I know the experience. Yeah, I know the
Yes.
experience. Yeah.
Yes, yes. So we will see whether we can sign up an MOU kind of relationship with your organization. Then we can send few of
Okay, ma'am.
our faculty members and
For
students
training.
who are interested. They can visit your facility and understand, how it is done.
No.
Yeah, you can. We can
No
also
problem,
invite
ma'am.
you, and let us see how we can take it forward.
Okay, ma'am. No
Yes.
problem. It's a good thing to do. We will be open to do this.
Yes, yes,
We are open to do this, yes.
yes.
Because this just like having a good relationship with Indian government as well. So
Yes.
it's
That's
a
required.
it's an advantage for both nations.
Yes.
An advantage, an advantage.
Yes. Yeah. Thank you very
It's
much.
okay.
Yeah.
Thank you so much, ma'am.
Thank you so much, Aisha.
Thank
It
you,
was
Kira,
very nice
ma'am.
having this
Yeshima.
session with you. Thank
Thank
you.
you so much, everybody. I appreciate.
Thank you. And thank you all the
Yes,
participants. Thank you.
Dr. Lata. Thank you,
Thank you.
everybody.
Thank
Be in
you.
touch. Thanks a lot, Aisha.
All right, ma'am. Bye, ma'am.
Bye. Thank you.
Yes.
Take
Thank you.